Kulatrakatu Ramesh. Here, not here. Where is he or she? Kumar Mukesh.
Present, ma'am.
Kumar Siddhartha.
Present po.
Kulatrakatu Ramesh. Kumar
Here, not
Mukesh.
here. Where is he or she?
Kumar Mukesh.
Present, ma'am.
Kumar Siddhartha.
Present po, Doc.
Okay. Kunat Mubishra.
Present, ma'am.
Lalani Naurin.
Present, ma'am.
Macherla Gayatri. Macherla Gayatri. Madugula Sirisha.
Present, ma'am.
Mahala Pranjal Anil. Okay, I see you.
Present, ma'am.
Maheshwari. I saw.
Present, ma'am.
Alangi Diwakar.
Present, ma'am.
Okay, good afternoon. So we will have our
Ma'am,
yes,
ma'am,
Gayatri.
ma'am, Kulatrakadu Ramesh Susmita is present.
I saw you. All right. Okay, so for this afternoon, we will have
Ma'am, Macharla Gayatri.
who?
Macharla Gayatri
Yeah,
Sauna.
Macherla. I saw you. Normal labor and delivery for this afternoon. Okay, so you have had your lectures on normal labor and delivery, and we will try to apply it with a case. As you see it in the ER, we will try to simulate as much as we can, but again, because of the pandemic, we cannot bring you to the hospital just yet. Okay, so for the meantime, we talk about a theoretical case. Okay. So this is a 23-year-old, gravity 1 para 0, coming in with a chief complaint of regular uterine contraction. You are the clerk at the emergency room, and how will you manage this patient? What are the things that you will ask at the emergency room to manage this patient appropriately? Anyone?
Doctor, we can ask.
Okay. Krishna Raj, what will you ask this patient? You're on mute.
Hello, doctor.
Yes, go ahead.
We can ask for a frequency of the contraction and then intensity.
Okay. Frequency of the contractions, your patient answered it's starting to occur every 30 minutes. And what frequency? Okay, so that is what she answered. Anyone else who wants to know a little bit more about this patient? What else will you ask? What are the important things that you have to know? Remember, we are at the emergency room setting. I know in OB1, you learned of your complete physical and history taking. But remember, we are at the ER setting. So what are the important things that you have to know, and you have to elicit it as fast and as accurate as possible?
Ask.
And we can ask if there is a rupture of membranes.
Okay, So in the history of present illness, you ask if there is watery discharge. Okay, who is that? Pranjal.
Yes, ma'am. Mahala Pranjal.
What else?
Ma'am, the intensity of contractions, ma'am.
Intensity of contractions. If is it a mild, moderate, or severe contractions? That's correct, Malangi. What else?
We could ask for the past medical history report.
What are the important things in the past medical history that you would have to elicit?
Like any familial disorders, genetic disorders in her family.
What are the important diseases of importance in obstetrics? When you ask for the past medical history, sorry. Mubashira.
Is there anyone in her family has asthma or
Okay.
hypertensive disorders?
What else? Okay, asthma, hypertension, diabetes. That's correct, Mukesh. What else aside from diabetes?
Ma'am, we can also ask if there is pain in the, the patient is having any pain in back, because mostly in case of true labor, there is back pain.
Okay, so the pain radiates to the back. You want to differentiate if there's true or false labor. That's correct. Okay, what else will you do? What else do you have to do?
Ma'am, her vital signs as well as the fetal heart tone should be checked.
Okay. Check for vital signs, check for fetal heart tones. Okay. So what else would you check for the abdomen?
Cervical dilation.
Your IE, what will you check for your internal examination, Macherla?
Hypogastric pain.
Let's do it
cervical
one by
dilation.
one. We're going abdominal, we're going internal examination. Let's do it one by one. Let's do it systematically. Even we're at the ER, we do things systematically. Actually, you have skipped the history taking part. Pregnant patient comes in. What's the most important thing to know?
Ma'am, vital signs.
Ma'am, age of gestation.
Age of gestation also.
So how will you get your age of gestation?
By asking LMP.
On the first day of LMB to the present day.
Okay. It's important to know your age of gestation so that you know if it's preterm or term. So LMP, you get your AOG by getting what? And your due date. How will you get your expected date of confinement? What? How will you get your expected date of confinement? This is OB1.
Ma'am, LMP plus 7 days plus 9 months.
Plus 9 months? It's easier. You
And
change
you-
the formula.
By
Plus 7
Nagel's
days
rule.
or minus 3 months, or some will do it plus 9 months. Whatever floats your boat. Okay. How will you get your age of gestation?
From the last menstrual period, doctor.
Okay, you count. Okay, number of days. So, for example, my last menstrual period is February 14. How will you count for age of gestation? That's not for the case. That's just for an example. So, how would you get the age of gestation of a last menstrual period of February 14?
We'll count back, ma'am, 3 calendar months from that date.
That is
Then-
your due date. Age of gestation so that you could get your pregnancy duration in weeks. So how will you do that?
As it is Feb 14th, we have 28 days.
Okay.
We'll add 14 days. 14 plus 31 plus 30, and in May we have 31, and June we have 7 days. So we'll add all those.
Giving you what age of gestation, Shivani?
Feb 14. So I'll add all these. 14 plus 31
3 months,
plus
14 days.
30 plus 30. 113 days divided by 7. 16 weeks, 1 day.
16 weeks, 1 day. Okay. So you know that the patient is term. So that was just for you to compute. Okay. So patient here has a due date of June 15. So you know that this patient is term. Okay. Complaining of contractions according to her every 30 minutes. Okay. Fetal heart tones is at 150. So your IE, what when you do your internal examination, what would be the things that you would be looking for?
Cervical dilatation.
Okay, cervical
Cervix
dilatation is what? What else?
The
Okay,
fetal station.
Fetal station, that's correct. What else?
And we'll do for bishop scoring.
Okay, what comprises your bishop score? Diwakar.
Cervical
What else? They have given two.
dilation.
Orangi?
Cervical dilatation.
Cervical effacement, cervical dilatation, cervical consistency, and fetal station and position.
Position. Okay. So, physical examination, 150 cephalic, head is floating, contractions 1 in 30 minutes, internal examination 1 to 2 centimeters, beginning effacement, posterior firm, station -2. What's your next best step?
Ma'am, wait and watch.
Wait and watch. Malangi. Any other dissenting
No
opinion?
need to admit the patient, doctor.
No need to admit the patient? With what could you do prior to sending the patient home? And this is to save yourself from possible lawsuits in case the baby is problematic already at this point, and then you will send the patient home. What could you do prior to sending this patient home if you will not admit the patient?
If the woman is admitted at exam course,
What?
and she needs more oxytocin. She
You
needs
will
more
give oxytocin, 1 to 2
oxytocin.
centimeters? You will admit the patient and induce the patient. Okay. You know what is this? What is your non-stress test?
It is used for fetal monitoring.
What are the components of your non-stress test?
Fetal heart rate and uterine contractions.
Okay, so one is your fetal heart rate. So you will know what's the beats per minute of your fetal heart. What else?
Body movement, ma'am.
That is your biophysical profile. You're confusing it with your BPS. One is heart rate. That's correct. One is contractions. That's also correct. What are the three other components?
Beat to beat changes, doctor.
Okay, your beat to beat variation. So, what else? One is actually written there. It is your acceleration and your deceleration. Okay. Your heart rate. What would comprise the normal heart rate of your fetus?
110 to around 160.
110 to 160. Okay. What would comprise of your normal variability?
5 to 20 beats per minute.
5 to
5 to 20 beats per minute.
is it 20?
20 or 25.
Okay, usually it's 25. Less than 5, we say it's minimal. 5 to 25, that is normal. More than 25 is marked variability. Okay. Acceleration. What is your definition of your acceleration?
With every fetal movement, I think there is a little bit acceleration in the fetal heart rate because there is movements.
Actually, it's written there. It's an increase of greater than 15 beats per minute from your baseline heart rate. Your deceleration is a transient decrease greater than 15 beats per minute from baseline. Of course, you have to have your acceleration, which means the baby's movement is good, your heart rate is good. Your deceleration, there are 3 different kinds of deceleration. Would you know the 3 different types?
Early deceleration, late deceleration, and variable.
There's early deceleration, there's
late
variable
deceleration,
deceleration, and your late deceleration. What is related to your head compression?
early deceleration.
It's your early. So if it's early, it's okay. Variable, as long as there would not be so many, it's also okay. We do not want any late deceleration because that would give poor prognosis. Okay. So this is a reactive non-stress test. So the baby is good. You are not, your Bishop score is what? Not favorable for delivery quite yet. So will everyone agree that we send the patient home? No other problems for this patient. So we allow patient to go home and await active labor. All right. Okay, so you advise that if the patient, most often you will see this in your primigravid patients because it's the first time that they experience your uterine contractions. Even if it's that, even if it's not that regular, they already go to the ER and seek consult. They also have low tolerance for pain because it's the first time that they are experiencing the labor pains. So you reassure the patient and tell her that she is far off from delivering and she may be sent home. Of course, you have proof that the baby is fine. Okay. After 12 hours, patient comes back. Okay, now contractions are every 5 minutes. Repeat internal examination is 5 centimeters, 50% effaced. Station -2, soft mid position. So how will you manage this patient?
Ma'am, we can admit.
We could
Admit, ma'am.
admit the patient.
Yes, ma'am.
What's your basis for admitting this patient?
Ma'am, the patient is in already active phase of labor.
In active phase of labor. What's your Bishop score?
Maybe 9. I think.
Maybe 9. How will you compute your Bishop score?
Yes, ma'am. I'll compute now.
5 cm is what? 550% is what? Okay, while he is at it computing, what is your definition of labor? Does it fulfill your criteria? So, definition of contractions, regular uterine contractions, bringing
Bishop score
about cervical change. So that will be your labor. So this patient is indeed in labor and we admit this patient. So when you admit the patient, what will you do?
We'll just keep monitoring the patient until the dilation is full.
Okay. How will you monitor this patient now that you've mentioned it? In an OB normal patient, active phase of labor, how often will you do your fetal heart tones?
Ma'am,
How
for
often
every
will
30
you
minutes.
do your internal examination?
Ma'am, fetal heart rate for every 30 minutes.
Every
30
for
minutes.
an OB normal active labor every
Every
30 minutes. For example, this patient has complications.
Then it should be 15 minutes.
Every
minutes, doctor.
15 minutes. How often will you do the internal examination?
For every hour.
Every hour. Some will do every 2 hours, but
2 to 3 hours.
every 3 hours. Because what is your basis? You estimate the time of the delivery of this patient. What's your estimated time of delivery of this patient? Remember, this patient is a crimigravid.
50
8
minutes.
to 12 hours.
What?
50 minutes.
8 to 12 hours.
8 to 8 hours.
How many centimeters will your crimigravid dilate every hour?
1.2 centimeter per hour, doctor.
1.2. So in how many hours would this patient deliver?
8 to 12.
If it's 1.2, she is at 5 centimeters. How many hours after?
5 to 6 hours.
5 to 6 hours?
Approximately 4 hours.
4
4
hours.
hours. I made it exact so that it won't be hard for you to compute. 4 hours. After 4 hours would be the estimated delivery time. But what are the things that you could do to augment the labor of this patient so that he or she may deliver earlier or deliver on time so that there would not be any um, regression of labor or protraction of labor? What are the things that you could do?
Artificial rupture of membranes.
Okay, you could do artificial rupture of membranes, okay, or early rupture of membranes. Okay, what else?
We can give oxytocin, doctor.
Okay, you could administer oxytocin. Do you know how to give your oxytocin? You usually incorporate it in 1 liter plain NSS or D5LR. 1 ampule, that's 20 units, that's 10 units in 1 liter. And then we run it at 8 to 10 drops. Okay, and then we titrate it every so often up by 2 to achieve contractions of every 2 to 3 minutes, moderate to strong. Okay. Why only 2 to 3 minutes? If it's less than that, isn't it better? It will allow the baby to go faster if the contractions more frequent than every 2 to 3 minutes. Why would the threshold be every 2 to 3 minutes? What is that phenomenon? What do you call that situation? If it's less than 2 to 3 minutes, what is that called? Anyone?
I mean, what are the contractions called? Are you asking?
What?
Are you asking, ma'am, what are the contractions called if there are less contraction?
If there are contractions every 2 to 3 minutes, more than, like every 1 minute, there's contractions. Is it good or bad? And what do you call that situation?
Hyperstimulation, I
Okay.
think so.
Your
It may
patient
cause fetal distress.
hyperstimulation and it will cause fetal distress. So remember to be judicious in your use of your oxytocin such that you will not cause fetal distress. Okay. If ever it happens, how will you reverse your hyperstimulation? What are the resuscitative measures that you could do? So,
Ma'am, we can stop giving oxytocin.
okay, one is stop the oxytocin. What else could you do? Agree, stop the oxytocin. What else could you do?
Ma'am, maybe anesthesia to
Anesthesia? How would you remove the excess oxytocin in the patient's body? One, you stop your oxytocin. What's the other?
Ma'am, if there is severe fetal distress, I think we can go for cesarean. If the fetal heart sounds
Right
are
away?
going
Cesarean
down.
right away?
And
That's why I am asking you to do resuscitative measures. So what could we do? Hyperstimulated. One, stop the oxytocin. How else would you remove the oxytocin from the body? You get your plain NSS without oxytocin and you can do fast drip 200 cc to wash away the oxytocin. Would you know the half-life of oxytocin?
1 to 6 minutes.
1 to 6. So actually, they say it's different, but suffice it to say the half-life of oxytocin is short. Okay, so after 5 minutes, you could wash it off. Okay, how would you resuscitate the baby? How would you make sure that blood will flow in, baby is alert? What other things could you do? So these are practical questions that will not be found in your book. And like it or not, you have to experience it, to know what to do. That is why I am trying to walk you through an OB normal until delivery. Okay. So if that happens, you put the patient in left lateral decubitus position to increase blood flow. You could do vibroacoustic stimulation. Before, it used to be a bell. Now, what I see the students do, they get a smartphone, play the audio player, and place it on the mother's tummy. Okay, and that is your stimulation. Or you could do your internal examination and do fetal scalp stimulation. Okay, and then once you recheck if your if your tracing becomes category 1, meaning your baby is fine, then you could restart your oxytocin. Take home message, oxytocin could be your friend, but always monitor it at bedside such that you would not cause hyperstimulation, because it does contribute to the number of fetuses that will go into distress, and we do not want that. All right? Okay. So what are the how will you deliver the baby? So we reach after 4 hours, baby reaches 10 centimeters dilatation. What would be your next steps? What will you do? Okay, so remember what we taught you in how to deliver a baby. Could you walk me through that? What are the cardinal movements of labor first? To refresh you.
Engagement, descent, flexion, internal rotation, extension, external rotation, and expulsion.
Again. Engagement.
Engagement.
Okay.
Descent. Flexion.
And then it will descend. Okay. And then?
Flexion.
Flexion.
This one.
Then,
internal rotation.
Internal rotation.
This one. Then extension.
Extension.
This one. Then external rotation. External rotation and expulsion.
And finally expulsion. Okay. So what are the steps when you do your spontaneous vaginal delivery? Okay. So it has started to descend. Okay, and it's now in your vaginal vault. Okay. What will you wait for before you do an episiotomy? Episiotomy?
For the crowning of the baby.
Okay. It has to be crowning, and your labia should be paper thin. Okay? anything earlier than that, when you cut early, of course, you will most likely cut into muscle because it hasn't been thinned out yet, and you will have a difficulty in repairing. But sometimes you have to do that. Okay. Ideally, paper thin. Okay. So how will you deliver the baby? So crowning. What's the next thing to do?
After crowning, there will be
Before you cut,
extension.
you insert your fingers so as to make sure that you do not cut the head, any part of the head, and then you do your episiotomy. What are the two types of your episiotomy?
Medial and mediolateral.
Medial and your median and your
Mediolateral.
mediolateral. What's the only advantage of your mediolateral cut?
That it prevent any damage to anal sphincter.
It will prevent any third or your fourth degree laceration.
Perineal tear. Yes, doctor.
Okay.
And it is preventing the lesion to the ischial tuberosity.
Okay. Your median is easier, is less bloody. The pain is less. And although your mediolateral has only one advantage, it's the only advantage that matters for some. I'm part of that. Okay? I am partial to your mediolateral. Why? Because it will prevent you from having a third and fourth degree, which is, in my book, a no-no in vaginal delivery because that would cause fistulas later on. Okay? But sometimes it does happen. It could be repaired even if you reach the rectum or your anal sphincter, but your mediolateral decreases your chance of getting a third and fourth degree. That's why I prefer that cut. Okay. Anyways, each would have their own preferences. When you cut and the baby would be delivered, how will you place your hands on the baby to deliver? How will you place your hands on the baby when you deliver it? Okay.
With one hand, we support the baby's head and another we slide through the shoulder to hold the baby as the baby comes out.
Okay. So you have your two fingers. One would be under, one would be over, and your neck. So if you're holding it like a ball, your two fingers are supporting it. Okay? And then how will you deliver the fetal head? Of course, your assist will do what maneuver? What maneuver that would aid you in delivering the baby?
Bridgen maneuver.
Okay, it's your Ritgen's maneuver. Okay, it's a perineal support that would aid in your delivery. For the that's for the assist. So for the one who is delivering the baby, so you deliver the fetal head by grasping the head with your two fingers, the neck of the baby with your two fingers. Okay. So what will you deliver first? So you bring down and deliver the what?
Anterior shoulder.
Okay, you bring down and deliver the anterior shoulder, and then
posterior shoulder, doctor.
and then what?
Posterior shoulder.
Head.
And then go slightly out upwards and deliver the posterior shoulder. Okay, that's correct. Then how will you deliver the body?
It will come out there. It will come out right side. You can easily pull it.
Okay. How will you deliver the body?
After delivering the anterior and posterior shoulder, the body will come out easily.
Where will your hands be? Where will you place your hands? You slide your hands up to what?
With one hand will support the baby's head and with another will slide through the baby's back.
Okay. You slide slowly and grasp the baby's feet. That's correct. Okay. So your elbow is supporting the head as you slowly slide. Then you get the feet. Okay. Then what will you do? You place your baby on the mother's tummy. That is for your essential newborn care. What's your essential newborn care?
Early skin to skin contact.
Okay, early skin to skin contact. Okay, what else?
Drying the baby.
Drying the baby.
To dry the baby. What else?
Suction.
No more suction.
Properly timed cord clamping.
Dry the baby. What else?
Properly timed cord clamping.
Okay, properly timed cord clamping. Where will you cut the cord?
5 centimeter from baby's.
Where?
Centimeters.
Where will you cut the cord? 2 centimeters and
5 centimeters.
5 centimeters. Okay. Early cord clamping. What else?
Breastfeeding, doctor.
Breastfeeding. That's correct. And you administer your oxytocin. Right. Okay. So the baby's there. Okay. You have cut the cord. So what else is left in the uterus?
Deliver the
Placenta.
placenta.
Okay. How will you deliver the placenta?
Is it through manually or
Placenta detaches exists through
Traction on your
deliver the baby.
But how will you deliver the placenta? You just pull it. When I was a clerk,
And we generally give
my
oxytocin
first delivery,
intramuscular.
I cut the placenta. My resident had to do manual extraction because I was so excited. So I cut the cord and left the placenta inside. No, so never do that. Anyways,
actually it's control cord traction?
controlled cord traction, that's correct. What is controlled cord traction? So you do a maneuver of pulling on the placenta while pushing the
uterus.
the uterus up. So it's a fluid motion. Okay. And what are your signs that the placenta is starting to separate from the uterus?
Lengthening of cord.
Okay, the cord will lengthen. What else?
Fresh bleeding.
Sudden gush of blood. Okay.
The most specific is suprapubic bulge on the abdomen, at the abdomen.
Uterus rises rises up the abdomen.
Yeah. Yes.
Sudden gush of blood, lengthening of cord, and uterus becomes globular.
Yeah.
Okay. So you have removed the placenta. What do you do with the placenta?
We inspect for any abnormality.
You expect for any abnormality.
Yeah.
What else?
We inspect that.
What are the abnormalities that you have to check for?
If there are any extra vessels, lobes, or holes on the surface.
You look if there are 2 veins, 1 artery. You look at the cord length. You look if the placenta is complete. And you check the cotyledons are not infarcted. Okay. So you have checked for the placenta. What will you check with the mother to make sure that she has delivered uneventful, that she had an eventful delivery? What are the things that you have to check?
We need to check for any lacerations, doctor.
You check for lacerations. Where would the lacerations be?
On vagina.
You check for any vaginal lacerations and repair as such. What else? Where else? Where else could there be lacerations? I've mentioned it. If it's a 3rd or 4th degree, where else would your lacerations be?
It can be until rectum, doctor.
Okay, you could have lacerations up to your rectum. And if there's instrumentation, your lacerations could reach your cervix. Okay? What else will you check for? You have checked the placenta, you have checked the vagina and the rectum. What else will you check for? What else will you check for to make sure that patient had an uneventful delivery?
Ma'am, we'll check for vitals.
Vital signs. Okay, agree. What else? You check for the placenta, you check for the vagina, and then you check for what? You just had a delivery.
Check if there is excessive blood loss.
Check for any postpartum what?
Hemorrhage.
How would you know if there is no postpartum hemorrhage? What will you check for? Hey, you have checked for I already said the answer. You have checked for trauma. You have checked for lacerations. Okay? You have checked for tissue. You have checked if the placenta is complete. What is the other T? I already told you. You check for tone. How will you check for tone? How will you check for tone? How will you check for tone? Aman Kundal.
Keeping hand on the uterus.
Okay, you check for the uterus. So look if the uterus is well contracted. And that makes more or less, if your uterus is contracted, makes it more or less likely for you to have uterine atony. Okay? So remember, always check your uterus, your vagina, and your placenta after delivery. So after, what the things we should monitor? Your vital signs. That's correct. And any postpartum bleeding. Remember, your postpartum hemorrhage could be late. It could be early. Early is within 24 hours. Late is more than 24 hours up to 30 days. Okay, what are the things that you will advise prior to sending this patient home? And this could save you a lot of trouble. How would they take care of their surgical operation, or how will they take care of their episiotherapy? That's the last slide. How will they take care of the episiotherapy? What will you advise not to do? And this is fairly common. What do these patients do? Who haven't I heard from?
Ma'am, avoid any unnecessary stress working.
Advise the mother to continue breastfeeding.
Advise breastfeeding, that's correct. So that would also be part of your family planning for 3 months at the very least. Another is your family planning options. Okay. And advice on the care of the wound. Okay. Often they wash with hot water, they wash with alcohol. And what will that do to your sutures? It will affect the integrity of your sutures such that your stitches will get broken and most will come back with a poorly healed episiotherapy because of that. So advise that they just wash with warm water to cold water and refrain from using alcohol as a cleaning agent. Okay? Any questions with normal delivery? Could you open your cameras and we will have a picture? Could the LO send it to me, the picture? One, two, three. Okay. Korangi, could you send it to the picture to me so that it's your attendance and mine? Okay. So see you Wednesday for your SGT on dystocia. Okay. So around the same time, around 4 p.m. Wednesday. All right. If you do not have any questions, you may leave this call. Thank you.